Hi, everybody. My name's Lauren Swagger. I'm a adult child and adolescent psychiatrist. I wear many hats. I've been a clinician for a long time, but I also have a foot in a lot of educational places. I'm involved with the Center for Excellence in Disabilities, Positive Behavior Support, and I have a job actually with Aetna Behavioral Health of West Virginia, which is one of the state Medicaid uh, plans. And I have learned a lot about the topic of behavioral health services that we're going to talk about today from so many different angles that my hope today in this presentation is take all the massive system of how behavioral health services and medical services, non-medical services are part of our very large system of care and share with you nearly 20 years of me trying to figure it out with you is my goal for today. And this was Teresa, this is for you. I redid this whole thing because I thought your questions were so great last time. So I hope today we also get a very lively discussion because part of this is that the behavioral health services system of care is so large that there are things I don't even know about. So there's going to be some interaction later on today. So my favorite thing about spring is the daylight. I am totally a need sunlight kind of person, and I am so excited that we lose an hour this weekend. So change your clocks, but that hour gives me my extra hour of sunlight that I love about spring. So, uh, Kelly, do you want me to start or any other things you want me to do?
You are good to go.
Okay. So I think one of the things, that I want to highlight is, the behavioral health services are some are medical services. We have a lot of clinicians on here, therapists, providers for medications, therapy. There are medical services that are part of the behavioral health system. And some of these are covered by insurance. There are services that are not covered by insurance. And then there's this whole idea of what a level of care is. And I think this is one of the things that's taken me a long time to truly understand about sort of healthcare is there's different intensities of service. And one of the things that I think is frustrating to providers, most frustrating to me to understood is when people talk about denying care, denying services, whether it's for meds or it's not about denying care. It's usually about the level of care or the intensity of care that, or which is the location that the care needs delivered or the frequency of the care is delivered that's being questioned in some of the reviews. And there are sort of criteria for those. And then there's a whole host of services that have nothing to do with insurance that are a critical part of our behavioral health service system. There are tons of services available by grants, available through additional non-traditional programming. This could be federal, this could be state, these could be private agencies, nonprofits that are in the community. And so there's a huge need and understanding of those services because as a clinician first, I may be the first to tell you, you know, behavioral health 101, you can't meet people's mental health needs if their physical needs aren't being met. If they're hungry or they don't have a roof over their heads, you won't be able to do anything with fancy drugs or therapy if someone doesn't have their basic needs and services met. So I think those of us in behavioral health care, at least I consider myself, I have to also function and understand socially necessary services and resources available to get people basic needs, because mental health does not survive without basic needs being met. And so there are a lot of different services that aren't available that interfere with treatment. I mean, how many people on this call have patients not show up for appointments because they don't have transportation? You can't deliver care if you can't get there, right? You can't deliver care if you're so hungry you can't make it through a therapy hour or a doctor's appointment because your stomach's grumbling and all you can think about is how where your next meal is. And so I think understanding those services and connecting people to those services is part of all our jobs in some ways too. And this is where I think it becomes very complicated. So I've really tried to learn more about this over the years and making sure it's part of the larger system is always important. So I do want to talk a little bit about insurance. And this is very, very basic. I'm not in any way, shape, or form an expert in this. I'm trying to learn more about it because I think, especially in today's world, where many of the programs are maybe at risk or under, I think it's important to understand how healthcare is funded, and where that comes from. And there are also massive differences in insurance that I don't think I always understood, even with my own plan, and what's covered and what's not covered. So this is very, very basic, but I hope is helpful to you. So one is commercial insurance. This is typically private insurance that does not receive a substantial portion of its funding through the federal or state government. So this may mean like you have an employer and your employer makes a contribution to your cost. You may make a cost. There's a monthly rate that goes with that insurance plan. It's all based on the risk and pool of the population that they have. If the pool of people their coverings needs go up, the rates go up and you pay more. And these rates may be very variable. Most commercial health, you can buy a commercial health insurance plan off the streets, but you might pay a very large amount for that. Most of the commercial plans are matched by private agencies. Then we have some of the health insurance types that have some federal and state funding for. Medicare is funded through the federal government. This is the plan for people over 65, and people that have a known disability and been recognized by such, um, for that usually permanent disability. And these rates, and guidelines are almost all determined by the federal government about what's allowed, what's covered, how it's funded, how it's monitored. They monitor facilities, they monitor quality, they have all the guidelines. They're all coming from the federal side with Medicare. Medicaid is the insurance for the poor, or people that do not have means. And you have, in order to qualify for Medicaid. Now, each state sets what they determine the eligibility criteria for. Each state determines that criteria, and there are usually some percentage of the federal poverty limit. In West Virginia, I think it's either 210 or 310% of the poverty limit. I don't remember the exact amount, but you have to make that in order to be eligible, and you have to verify your employment to qualify for that. And Medicaid can cover children and can cover adults that meet those guidelines. Now, Medicaid is funded differently in each state. A very large percentage of Medicaid is funded by the federal government. In West Virginia, it's 70% funded roughly by the federal government and 30% funded by the state. That percentage varies from 50 to 80%, depending on what state you're in. And it's sort of a per capitated rate at this point. So states have to set their eligibility, and states have to figure out how to pay the state-based portion of the match that they get from the federal government. So, but states determine these rules. While there may be some federal things that you have to do to get the funds, states decide what they cover with Medicaid. States decide how they fund each rate, for the service that you might bill. So the state sets the rate for maybe a medication check, or the state sets the rate for an inpatient hospital stay, or the state sets the rate for that. And the states may also have rules about their prescription coverage and tiers from a lot of those rules. In West Virginia, we now have four Medicaid agencies that monitor this. And if you qualify for Medicaid in the state of West Virginia, if you don't pick a plan, you'll be randomly assigned to one of these four plans that may manage it. There's also a traditional Medicaid that I honestly don't know all the details about, but people that may not qualify for an MCO. Some of this sometimes is seen in folks that maybe have like IDDD waivers or getting their Medicaid services through the more traditional route, may not go through a managed care organization. There's also a couple other insurances just to touch on, there are people that qualify both for Medicaid and Medicare that may be over 65 and below those poverty limits. And so those types of insurance plans are called duals, and they have competing needs they have to meet sometimes for those. And then we have the CHIP, which is for children, CHIP health insurance program. And in West Virginia, CHIP and Medicaid are managed together, but there are some differences. CHIP is just for children, and it's designed to sort of fund that gap where working parents, so it has a higher level of what the parents can earn on that poverty thing to qualify for CHIP. So you might not qualify for Medicaid because your parents make too much, because this is for like working parents that don't have access to commercial plans or can't afford commercial plans, make too much for Medicaid, but not enough to really fund a private policy. So this is really designed to protect children so that they got health insurance. And so this is kind of that group between Medicaid and I think the CHIP one's 310 and I think the standard might be 210, but I'm not entirely sure about that specifically. But CHIP does include more kids than Medicaid. So that's a little bit of this. Now, when you're talking about Medicare and Medicaid, especially Medicaid, there's very little cost to the person that is receiving that. They're receiving that service because they do not have the means to pay for it directly. So it's important to remember, when talking about Medicaid services, these are all largely taxpayer funded. You aren't there's no I mean, they don't usually have copays beyond $1 or two, a few bucks. You can't bill them if they don't pay. A hospital can't charge someone for a non-approved stay because that's part of the issue. And so when Medicaid loses money or doesn't have money coming from federal, the state is either going to have to make it up or taxes will go up because these are completely large chunks of the federal budget. So if you are a political person, these are massive discussions happening. There's currently requests to find $880 billion to reduce the deficit by, and there are only 3 programs that would even get close. So Medicaid, Medicare, and Defense are a large chunk of that. So many of these programs are clearly topics today. But understanding the funding of that is helpful. So we're going to talk a little bit about some of the things that are covered in the healthcare system by medical services. And medical services also have to talk about the level of care of medical services and understanding the range of those services. So there's some levels of care that are determined to be inpatient levels of care. And understanding this term and what you need to need that level can be really helpful if you're doing assessments. And when I talk about levels of care, especially about mental health, we're talking about, do you need daily medical monitoring or nursing monitoring? Do you need a locked door because something is so unstable that you can't be kept safe if you aren't monitored 24/7? And so we think about a psychiatric inpatient hospitalization, which was acute care, the needs for that are that someone is emergently unsafe. They have active suicidal ideations, or they're actively psychotic. They're going to need their medicines looked at every day. They might need emergency medicines. We'll talk a little bit more about that a little bit later. And then there's a subacute level. You may not need acute care, but you might not quite be stable yet for a step down. In the state of West Virginia, we also have something called crisis stabilization units. These aren't technically inpatient units, but they're like emergency beds to stabilize a rising problem or concern, either related to substance use or behavioral health. But they're trying to stabilize before it gets to the need for inpatient care. In West Virginia, this service with Medicaid is only available for adults. There's not a child crisis unit yet. And then we have 2 levels of substance use care in the community that are kind of considered intensive inpatient services. One is an ASAM stands for is the acronym for the Society of Addiction Medicine, American Society of Addiction Medicine. So they have different levels of care if you've not heard that. The 4.0 level of care is a managed level of care where you need to be seen by a doctor every day. And then the ASAM 3.7 level of care is medically monitored, which means you need access to 24-hour nursing. We'll talk about that here a little bit more too. So inpatient care is you need that locked door. You need access to nursing staff 24/7. The doors are locked. You have ligature risks so that you're not in an environment where you might harm yourself. You don't have access to sharps. And you're going to be seen by a doctor every day. And you'll have nursing there for emergency delivery of care. So things that require inpatient care are there's an active current suicidal risk, maybe with a plan or intent that even in the home, if their loved one is asleep, they're at risk of harming themselves. They can't contract for safety in the community, or they're having active thoughts to harm someone else. And this is truly from a psychiatric condition that's treatable. They may have failed outpatient services, but you don't have to fail outpatient services necessarily for inpatient care. It just has to need that intensity of observation. Usually there's some significant dysfunction that's happening, like you're too ill to be able to work or go to school. Or maybe there's something like aggression that's very acute, that you're at risk of impulsively acting out and harming someone, or something immediately happen. Where with kids, that might be you made a threat at school, or you had a significant threat or injury that you inflicted upon yourself. So usually there's some significant dysfunction, and these symptoms have been there sometimes for a while, but have risen to a level that they need that level of safety. The step down subacute is not available in every hospital. I'm only aware of one subacute level. These are usually sort of contracted levels with the insurance that pay a reduced rate for inpatient because they're not quite ready to go home or step down, but they don't really need a daily doctor's visit, but they still may need some more intensive nursing care. The crisis stabilization units, there are several. Someone might go there for a non-complicated detox that isn't life-threatening, or maybe they have some passive suicidal thoughts or some severe depression that hasn't quite crossed the line to needing that 24 hours. But if they didn't get their meds looked at or didn't get that detox, they really would be at risk of going to the hospital. These services are provided in facilities in like 15-minute units, usually a crisis stay somewhere between 3 to 6 days. It's sort of, again, just a level of care right below that acute care. The substance use levels of care are all going to have that ASAM sort of acronym and then this number. The 4.0 is very much like an inpatient psychiatric unit. They're going to need seen by a medical provider every day. And they evaluate them in dimensions. There's 6 dimensions for 4.0 and 3.7 level of care. We're only looking at those dimensions 1 through 3. So dimension 1 is your risk of going through withdrawal. So you may be acutely intoxicated. You may need a taper. Example would be alcohol. If you were not safely detoxed from alcohol, you could die and have delirium tremens, and you need someone daily checking on that taper, monitoring your vital signs, monitoring for withdrawal. Benzodiazepines also clearly require a taper for safety, because these are benzos, barbiturates, and alcohol. You can die from withdrawal of those substances, and so you absolutely need this 24-hour environment to do that. Dimension 2 are the medical conditions that might be impacted by the detox. So maybe the diabetes is unstable, hypertension is unstable, being affected by that. Wound care, perhaps you have used IV drugs and you may be having skin infections or need for IV antibiotics that obviously cannot be delivered lower. You may need this level of care for that. And then 3 is the presence of other psychiatric or mental health conditions that are quite unstable. So perhaps you have been using methamphetamines, and not only do you need substance use treatment for meth, but you actually are psychotic from the meth use and agitated and may need emergency medicines. Those would all be situations where you would need this highest level of, of, of medical care for substance use. The 3.7 levels of care, just like a step down. You may not be seen by a doctor daily, so you're not that ill, but you do have access to a doctor. You still have access to 24-hour nursing. So this is a little bit more high risk than you would see in an outpatient or residential setting, but not requiring the full array of services of a fully licensed hospital. So you probably aren't needing oxygen. You're not going to necessarily have an emergent medical condition that will destabilize. But perhaps, so this is if you have really severe opiate withdrawal, maybe you're vomiting, maybe you have a comorbid seizure disorder and opiates, that you need that extra monitoring for electrolytes. Um, a lot of times there's sort of also this moderate severity, again, not an immediate safety issue like they're actively psychotic or suicidal, but they're having significant trauma symptoms, significant conflict with domestic violence and trauma in their environment. And it's really impacting their ability to get treatment in different settings. So this is a medical stay, usually about 5 to 6 days as well. But for those that are less risk of severe withdrawal. So this would be an uncomplicated alcohol detox. Maybe someone that's mildly agitated from meth, but not psychotic. Those could all be things that could be managed at just this little bit lower level of substance use care. So those are all the cute, those are their intensive units of care. The next step down is residential care. And this is a really, really complicated level of care to understand. There is psychiatric residential treatment facilities. There are technically residential treatment facilities for children. There are residential treatment facilities for adults. In West Virginia, there really are not a lot of residential treatment facilities for adults for long term. There are children's services that are more long term. Typically, a residential stay is 3 to 9 months. In theory. In the state of West Virginia, we also have labeled our group home care as residential care, which I think causes lots of confusion for people outside of the system. So there are 4 levels of residential care for children. And in other states, this would be like a group home with sort of outpatient, a little bit more intensive outpatient mental health services, but they're living in a group environment. There are 4 levels in the state of West Virginia. The levels have more to do with the staffing needs and the supervision needs than specifically treatment needs. And so they have very specific criteria about like if you have to have an on-ground school or an off-ground school. By virtue of these levels, you have to not have a community placement. So these kids are all in custody and don't really have a home, but may need some degree of intensity awaiting a step down or a step up. We can get more into that later. I don't want to really go into it, but these are not truly psychiatric residential treatment facilities. They have their own sort of levels of care, and you have to be in DOHS custody to access them. Some of the adult, oh, yes, I do know where the state is. So Deborah, it is all paused right now, which I think is unfortunate. We were trying to revisit this because the hope was a lot of the kids in level 3s and level 4s are kind of getting a lot of intensive services, kind of close to a PRTF level of care. A lot of the level 1s and 2s are kind of more outpatient. And so there was really a hope to reset this system and really apply actual treatment guidelines and level of care guidelines because they were trying to actually pay providers more for the care they were giving. And I think everyone freaked out at the change. And there was this massive pushback that no one wanted the system to change, even though we were trying to actually pay people more and get people in the right level. I would say right now, the problem with this is no one's in the right level of care for the right amount of time. So it was really a hope to restructure this and call it high intensity group res and a lower intensity group res. But there was so much pushback with the change. There was a massive change in administration that was happening at the same time. It literally all got paused. So I do not expect that restructuring to be opened up again until the new governor and administration is all in place. I have not officially named the PSS commissioner yet to really even move forward with it. So I think that may be coming. And I think it really is beneficial, and I do think they were moving in the right direction with it. But I think change caused a lot of anxiety, and there were changes beyond that. So I do think that conversation will continue because it's needed. Um, I think desperately needed. But I think it's still going to be probably another 6 to 8 months before it's opened up again. And then the other type of group, sort of residential care, is for people with developmental disabilities that might have chronic developmental needs that can't be served in the community, or they do not have caregivers that can be part of that. And these are those ICF facilities, intermediate care facilities, that are group home cares for adults that have met criteria for the IDD waiver, which we'll talk more about. And they're, again, homes sort of designed to be kind of unique to developmental needs of an adult with maybe chronic ADL supports and assistance. So the criteria for a psychiatric residential treatment is that you have some chronic kind of undergoing safety risk that's not resolving with outpatient care, can't resolve with outpatient care, has consistently failed outpatient care, had so many inpatient admissions that perhaps you can't get to that. So it's a step down kind of from acute. Again, the stays are usually 3 to 9 months. Usually we don't see much improvement beyond 6 months. It seems to be about 3 to 5 months is the ideal. But these are for maybe folks with like chronic ongoing suicidality, massive interpersonal challenges in their home that aren't getting resolved, sort of reoccurrent impulse control or aggression, and that's causing chronic issues at school. Uh, Maybe people that have had intensive in-home services in the community and school and have been failing those. There's not an expectation of need for seclusion or restraint, but a possibility. And they're still having pretty severe chronic behavior. So it could be something like continued substance use despite services because you're sneaking out to keep using. Maybe sexually reactive behaviors, uh, impulsivity leading to harm, recurrent self-injury that have really not made progress at lower levels may meet for this care. And this does include that 24-hour supervision. That the facilities are usually not locked. So some of them may be locked, but many times they're community-based programs. They don't have locks on the doors. So if you really need someone watched one-to-one or that degree of 15-minute checks, that's still acute care. This would be needing sort of, again, pretty intensive supervision, but not maybe eyes on at all times supervision. These children's residential facilities right now are listed online if you're curious what this is. This is a 503 chapter of the BMS sort of code. And this is what Deborah was asking about. This is what's been proposed revisions that have just sort of paused at this time, but this is still the technical levels. There are also substance use disordered levels of care that are, again, recognized with this ASAM label, and there are 2 levels to this. And you can see this level kind of mimics what they were trying to do in the children's residential level, and it's kind of a natural transition of the new plan for kids. But the 3.5 level of ASAM care is your high intensity residential service. This is a facility that really gives access to 24-hour mental health counseling, and people are getting case management, people are getting medical services, but they're getting pretty frequent mental health care. So to put it in perspective, they may be getting more than 10 hours, 10 to 20 hours of some type of care a week. It could be individual care, could be case management directed care, it could be individual therapy, it could be group-based therapy, maybe peer support recovery services, maybe part of that. They're getting pretty intensive treatment in a contained facility. With if you had a crisis and you need to talk to someone, there's always someone there to speak to. And so this is a step down usually from a 4.0 or um, a 3.7, especially for someone with really intensive needs. So this may be someone that has had multiple attempts at sobriety, multiple failures at sobriety, multiple attempts to get clean, maybe multiple AMA stays, or there may be really profound mental health or physical health issues that prevent them from being successful. Maybe they're having horrifically horrible pain control, and that's driving substance use. Maybe there's profound trauma or severe depression that's impacting their ability to have success. So the 3.5s are really sort of that intensity of service for both the substance use, mental health, and physical health um, needs. 3.1 is the lower intensity residential service. They're getting a minimum of 5 hours a week of care, usually group or individual, so significantly less. A lot of the 3.1 stays are between maybe 2 months and 4 months in duration, and they're really hoping someone who doesn't have any support in their community or no safe housing or support system to get services and maybe really helping them get an ID, get a job, find a sober living household, or apply for HUD, or sort of rebuild their lives. There's a lot of rehabilitation needs at this level. Um, there also is sober living. It is not an insurance driven. Some of the sober livings have merged into 3.1s in some states. They're still fairly separate in West Virginia, and right now sober living is not reimbursed through the SUD Medicaid waiver, which we'll talk about in a minute. But they often do have direct access to like intensive outpatient medical and substance use services alongside sober living. So in West Virginia, sober living with an IOP may be very similar to the type of care someone's getting in a 3.1. But sober living usually pay a fee to stay at sober living. There's a rate people pay. The medical piece and the outpatient piece is covered usually with their insurance. So people do have to have some usually clean time and apply to sober living facilities and be accepted. Often it's a step down from 3.5 or 3.1. And again, if we want to talk about those dimensions, I told you what 1 through 3 was. The dimensions 4, 5, and 6 are the other areas that sort of determine change. And I will say these dimensions are changing with the 4th edition. These are still the 3rd edition. So if you are an ASAM expert, the state is going to begin using the 4th edition in July 1st, I believe. And it does change Dimension 4 a bit. But right now, Dimension 4 is your readiness to change. 5 are the risks of continued use, and 6 is what is your current living environment and recovery support. And you see with 5, you're meeting in all these categories. There's not significant acute medical problems, but sometimes still some significant mental health issues, some challenges with change, and often there's no supportive recovery environment, and the person may not have skills yet to not cope without that 24-hour access. 3.1, you see those risks kind of go down a bit, more minimal. They're making gains, but they still need a fair amount of structure. Okay. And then the next levels are kind of more the outpatient service levels that are often covered by insurance. So that may be outpatient psychotherapy. Your hourly psychotherapy visit may include ABA therapy. It may include a medication management visit with a psychiatrist or nurse practitioner. They're also per diem services that are more intensive outpatient services. So there are IOP programs. Instead of billing each service, they get a one rate for a daily rate for being an IOP. There's also partial hospitals where you go every day, but you go home to sleep. And there may be a different per diem rate for a partial hospital. There are different types of psychological and neuropsychological testing that can be asked for on an outpatient basis. There may be interventions like ECT treatments or TMS treatments that may be requested. Physical therapy, occupational therapy, speech therapy, maybe services covered medically. And then the SUD waiver allows for substance use services, again, at these per diem rates, where you may have an outpatient partial hospital program, just 20 hours a week of treatment, but you go somewhere else to sleep outside of the facility. That's a 2.5. A 2.1 is maybe 3 to 5 hours. 3 to 5 days of treatment for a total of up to 20 hours. So usually between 9 and 19 hours that will be served in an IOP. And then basic outpatient is maybe more like your weekly therapy, your monthly psychiatry level of care. So less than 9 hours a week. Okay, so those are the services and levels sort of covered by insurance. But again, there are lots of services that are maybe partially involving insurance, but may also have other sort of requirements or definitions. So in the state of West Virginia, we have 5 waiver programs right now. Each of them have their own sort of criteria, and I will touch on these. So we have a children with serious emotional disorder waiver. We have the intellectual and developmental disabilities waiver. We have a traumatic brain injury waiver. We have an aged and disabled waiver. We have the substance use disorder waiver. I'm going to touch on all of those. So the children with serious emotional disorder waiver was launched in 2019. It was a waiver service really designed to try to increase and prevent out-of-state placements by increasing the intensity of services available to kids directly in their community and specifically their homes. And so it was based on a model related to wraparound. And in order to need these services, you have to show some significant functional impairments at home, school, and really be at risk of, of really needing a PRTF or residential level of care to qualify. So you have to have a clear diagnosable mental health condition. It's available for ages 3 to 21, and they do something. I'm sorry, I'm not going to remember all the letters. The Acentra is the state agency that does the interviews and assessments to see if people qualify for CSED. And you have to have at least above a 90 or at risk of out-of-home placement to qualify. And then once you qualify, you may have access to many, many services. Some of these services, like in-home therapy, you could get in the community, and you still may get in the community if you have a therapist, but it also includes a bunch of services that you might not have been reimbursed for if you did not have it. So one of the things it covers is wrap facilitation, which is someone coming in the home. It's not therapy per se, but they're providing that wraparound support. They may be assisting in a lot of the case management, referrals, communication with a therapist, maybe doing communication with the school, maybe part of building the safety plan, providing some of the parenting services. It can cover therapy in the home. It can also cover other things. It can cover some transition services. Kids are coming back from placement. It can provide some rehab and transitional age services for youth that might be getting ready to become adults. There's 13 actual different services that you can be eligible with for CSED, including giving some family respite and paying respite workers to care for their kids. So there's several services. If you're approved for CSED, you get assigned a case manager through Aetna. So I have a lot of work with CSED on that side of things because Aetna Better Health of West Virginia does their case management to support that piece. But but there are several providers in the community that are CSED providers. I think we may even have some on these calls that are delivering this care, and they will safety plan. They will do follow-ups after inpatient care. They meet when you need to rework the plan, and maybe sort of determining if they're meeting their needs and they're having frequent things they have to do as part of that waiver. But in order to qualify the waiver, you have to really do need that intensity of service. And it was designed to last for about 6 months. I think the reality has been that those people that have gotten CSED and felt it helpful have been very, very, very concerned about lowering the service and transitioning. And I think transitioning back to regular community has been a challenge. But in is it going on 6 years? I think I'm going to misquote it. We're well over 2,000 kids now that are receiving CSED services. To make a referral for CSED, um, you can actually call the 1-800-HELP for West Virginia line as a provider and make the referral that way, directly to Essentra. Caregivers can also call. They'll set up an intake appointment with you. The details about the CSED program are at this website, and the direct contact number for Essentra is also at that website to make the referrals. But it can come from a provider, it can come from the caregiver themselves, it can come from DOHS. If you think a child has more intensive needs for services at home and in their community, and maybe are failing outpatient, please consider it. Then in the IDDD waiver, or intellectual and developmentally disabilities waiver, is much longer in its origin. Goes back decades to, I think, the 50s or 60s at this point. It was really designed to help folks with intellectual and developmental disabilities stay in their homes and their communities with sort of services correcting for their cognitive needs, either behavioral or language or communication, to really try to keep them in their homes. But it did recognize that, and this is that the idea was to keep them out of facilities, those intermediate care facilities and group residential services, and engage with their community. So the criteria, for IDDD waiver is here in front of you. It's available for adults and kids. It's really supposed to be for folks that have a clear intellectual disability or developmental delay like autism. Yeah, I'll talk, Teresa, I'll ask you, I'll talk about that in a minute. So there's some challenges with the IDD waiver and funding. The IDD waiver has really been jeopardized, I think, over the years. In fact, I think the creation of CSED, many of the IDD providers moved to CSED. So there's some significant provider gaps, I think, that happened with creation of that waiver too. But it was really designed for people that had IQs typically below 55 and some significant severity in at least 6 of those conditions that you see there, and that there was some degree of chronicity to it. So autism and specifically, so there's the assessment for the IDD waiver included, having an IQ measure, but also some functional measures that were showing these deficits. The wait lists for the IDD waivers are quite long. They're much longer than CSED. CSED actually has made a lot of progress with their wait lists. There are not as many wait lists with CSED anymore. There have been some state-approved people that can cross sort of county lines. So CSED wait lists can be a little bit dependent on the county being served, but there's been massive growth in that provider. So we see CSED wait lists much shorter than they were even just a year ago. And that's really been a huge effort to expand that. I think with IDD waiver right now, there are only X amount of slots. So you really, if you cannot, they can't just add slots. The way it's funded, you literally have to wait for someone to not need the slot, which either means they often die, they don't qualify anymore on retesting, or they've moved to a care facility and gave up their IDD waiver. So it's a little bit, it is very challenging. I had one, this was years ago, I had someone wait, I think almost 6 years for their waiver slot. So if you identify a cognitive disability early on, it is important. It has to be before 22, so you should apply because and wait. Because once you get that slot, it's usually yours, and you can usually have it forever if the condition's permanent. But there's really, you need to do it as soon as you think you should. And it is challenging. And Deborah is correct. It is very hard if you don't get that identification early to prove it happened before 22. And again, I am not an expert on any of these, so many of you are probably more knowledgeable about it than me. CSED was really designed, you're not allowed to have two different waivers. That's the other part. So I will say that one of the real challenges, and those of you who have heard me talk about this before, is as seeing children from our substance use epidemic happen, we're seeing a lot of cognitive concerns in those kids, and a large chunk of those kids are living in kind of the 60 to 80 IQ range with some cognition deficits, but they're not significant enough usually to meet full criteria for IDDD services or even maybe school services based on intellect. And then we're seeing all these behaviors. And so I think one of the challenges of CSED has been sometimes they're seeing cognitive challenges that aren't responding to the traditional behavioral health interventions that would maybe be delivered like CBT or something, because they're not able to cognitively do those services and having to adapt down to maybe more behavioral or PBS type services. And that's a challenge in that group. So while you can't have both, we do have kids with CISA that are awaiting an IDD waiver slot. And it's complicated. And again, if you do get approved for the IDD waiver, these are some of the services available to you. Much like CSED, there's a team. The team meets, they decide what services are needed, they monitor the treatment plan. Not everyone gets all the services or needs all the services, but that's part of the team planning. Traumatic brain injury waiver is also a waiver. I think people know less about this. This is evidence of an actual documented traumatic brain injury that's usually by physical force or lack of oxygen that got medically severe enough that you needed nursing care kind of at home. And so there's again I admittedly don't know what this scale is. I don't do these assessments. This is just straight off their website. You have to clearly have met some criteria of cognitive functioning impairment for this. And it, much like the other waivers, will open up some in-home services. Again, attempting to try to give you those services in the community instead of having to go to a rehabilitation hospital or nursing home. The aged and disabled waiver is for older individuals. So you have to be an adult for these services. But there's, again, such a need for almost a nursing home level of care that you would need assistance with all these ADLs and almost need nursing care services. But again, they're trying to put those services in your home so you don't have to be institutionalized. And you can see the criteria for that as well. And then the substance use disorder waiver, which is not really in the same category of these other waivers, but it is called the substance use disorder waiver. Substance use disorder waiver falls under the BMS Chapter 504 services. This is also being revisited at the state level, and changes are happening to this waiver as well. But this waiver is now going in, I think, to its third phase. But phase one was creation of the SBIRT programs to begin screening and providing methadone and distributing naloxone. Phase two is building in all those residential levels of care that we did not have in West Virginia a decade ago. They built that, they funded that through those ASAM levels, through the waiver, and included peer support recovery services and other substance detoxification services like the 3.1 outside of hospitals. And then I'm going to fly through this because I'm way out of time, and I know I could talk about this forever. This may be something we want to do more of in ECHO, and happy to. There are all kinds of other services available that, again, are not funded by insurance. That may be, you can get RAP facilitation with CSED, but you can get RAP facilitation without CSED. You can get RAP facilitation just with your parent, get that intensive case management. You can call mobile crisis, and in some areas, they'll send mental health support to your home instead of calling like 911. Safe at Home is a DOHS program also designed to put RAP facilitation in through kids at risk of going into DOHS custody or already in DOHS custody. There's a Quiet Minds First Episode psychosis program. I'm going to skip this just so you can have these slides. And then there are all these other socially necessary services that are critical to people's success. Right from the start, helps give some nursing care to new moms and babies or pregnant moms in their home so they can set people up for success. There's birth to three services, women's, infants, and children's may help with services. There's nutrition support, housing assistance, transportation that's non-emergent medical. So anyone with Medicaid can actually get transportation to their appointments if they don't have transportation. There's family support centers all across the state. Every county has one that's funded by the Bureau for Family Assistance. Families can go to those services and even get access to childcare resources, parent support. They're incredibly grassroots, knowing what their local things have. They might connect to food banks or other agencies. There's community action agencies that are funded. Some of them are covering actually our early Head Start and Head Start programming in the state. There's food banks and food pantries that are critical to services. United Way is you can go to West Virginia 211, and if you've never called them, this is funded by the United Way program, call them and say, I need this in this county, and they will help you find who that person is to get that service through many of these different organizations. The West Virginia Division of Rehab Services provides vocational services, job training, educational support. I know I got my PBS team on this call, but the West Virginia Center for Excellence Disabilities is a lot of grant funding program that provides a lot of mental health options and services. Our PBS team is funded through grants through this program. We also have Family to Family, Path for Parents. There's specific programming for parenting with children and services for children exposed in utero. There's Modify, which helps with independence and college and education and vocational initiatives post foster care. There's specialized family care, regional transition navigator services, helping people find housing. There's assisted technology programs. There's a lot of different ways to find things. And then at the end, and with 6 minutes left to go, I know I didn't even touch on half the things that are probably out there. And so if any of you know of other services providing core support for the behavioral health services, please stick it in our chat. I think I always learn more from things I don't know in some of these things about how to access services. But there are many, many things that are out there to get people support. And I think of all the things I have learned in my 2 decades plus now working in mental health is we need a village. None of us can do it alone. So I'm going to pause for questions. I said that was really fast. I didn't want to not comment on things, but the healthcare system is very, very broad. And I think as much as you know, as much as we learn, as much as we share, we do better for our clients and patients. So, are there any questions?